Very thank you for APT to invite me here to give this talk. Mastering Retrograde, their Septal technique for successful CTO recanalization. So I'm just going to start. So the first thing to do when you're looking at tackling a CTO, you need to review the Kare Tang very closely. And it could be an angiogram that's been taken by your colleagues, or Kare angiogram during the case where you do dual injection. So looking at septals, collaterals, interventional collaterals, looking at the epicardial collaterals, and just see what connects to the CTO. Another thing that's very useful is CT coronary angiogram, so that you can see if there's any calcification and other tracks that may lead to the CTO. And then obviously make sure you've got all the tools you need on the shelf. Okay. So microcatheter, number one, you need a microcatheter because that is a game changer when it was introduced. That allows you to go retrograde, and different microcatheters on the market. And generally, you need something that will go antegrade and retrograde. You need guide wires. Guide wires that is able to select the septal, to traverse the septal, and then guide wires that's going to puncture the distal cap and complete the CTO. You also need a wire to externalize as well. So in order to connect the retrograde to the antegrade, in order to externalize and allow you to perform and complete the CTO procedure. So the wires, retrograde wires that's available at the moment, I think most would agree that the Cyan Black has been the mainstay, and then the CO3 has been a good one, but the Anti-Rich P 0.3 grams is equivalent to the Cyan Black, and that has been very good as well. The first thing is the tip. What tip you make in order to go for septal surfing. And it's vitally important to maybe cause whether your case is going to be successful or not successful in navigating the septal. So it needs to be a 1 millimeter bend, usually about a 90 degree. You can get as close to 90 degree, maybe 80, 90 degree. The reason for this is that going through septals, there are very tortuous vessels and many branches coming off the tortuosity. The vessels are small, so you need a small bend in small vessel. Okay, the bend got to be small, and the idea is not to push. Okay, is to spin the wire and let it find its way through. Usually in diastole. Okay, where it will then send the wire through. So small bend is important. Sometimes you may have to make a secondary bend in order to get around certain proximal to get the wire in through the epicardial into the septal. But generally speaking, small bend and 90 degree. Okay, that's what you need to remember. You need a guide extension catheter that is going to be from the antegrade in order to bring the way of entry into the antegrade segment as close to the retrograde as possible. For a retrograde case, you need the antegrade and the retrograde, so they all go hand in hand. The question is whether you do the antegrade first, whether you do the retrograde first. Of course, they both need to be done. Okay, you need both sides. So I'll just show you some images. So this is a dual injection. Let me just click on that. So what you see here is a occluded right coronary artery, occluded LAD as well. This patient has had bypass. There's a lemur to the LAD. So we try to avoid the lemur most of the time. But the good news is that the LAD is occluded after the septal. So that allows you to get access via the septal. So you look at the angiogram and you try and identify where the vessel is the septal is connecting. So looking at it closely, you can see there's a big branch that comes up. I'm going to show you here, coming down here. And there's another branch coming down here. It all tends to do a sharp turn around here and then connects up to the distal vessel. This is the antegrade section. There's a guide wire there just to keep the guide in place, and that's another tip to do. Okay, have a guide wire down there to keep the guide to stay in place. So this is trying to wire it. This is just out the way. So you can see there's a microcatheter in the retrograde part of the vessel. You can see the wire is any rich C wire just to get into the septal. You can see now I've selected the septal, then you advance the microcatheter over the septal. And what I tend to do after is to do a selective microcatheter injection. The reason for that is that when you do your retrograde injection, sometimes there's so many vessels in the way you can't quite see which vessel it is that is overlapping. Sometimes you get fooled because the overlap because it's a 2D image, and therefore you select the wrong one. So I always tend to do a selective injection just to check that it's all working okay. Let's go back here. So there's a select. You can see there's the two branches. There's a big branch on this side and a smaller branch on this side. They both seem to connect. And when you do the injection, you can do a flushing with saline after. You get a second injection for free, basically, with nothing. So that's a good thing to do. So select your septal, decide which way you want to go, and then you do septal surfing with one of the wires I've mentioned. And this is a septal surfing. You went down one branch, it didn't quite work. You go down another branch, and what you see is the tip, it buckles. The thing is not to push so that it loops, okay? You feel it buckle, there's resistance. The idea is just to spin the wire, and the wire will then select the track. And obviously, if you've got the 90-degree bend on it, it will go into the collateral and follow the way through. So this is continuing on, and you can see, again, there's a buckling there, and sometimes you're not sure, are you in the right place? Always do a injection just to check whether your position's in the right place. So this is, let's just put it there. Okay, so do an injection, check position, make sure you are in the right place. And if it looks like it's in the right place, then you carry on. The thing to do is then bring the microcatheter, follow the wire to give support for the wire. Okay, the closer the microcatheter, the more push you have, the further away, the less push it has. And sometimes if you're not overly sure, don't commit with the microcatheter, because obviously it can damage it. To give you so much push, you can perforate and cause septal hematomas. But generally speaking, just bring the microcatheter down to where the dark bit of the wire is. Okay, so be patient, just spin the wire and just watch it go traverse and get through into the vessel, the branch that you think it's going to do. So sometimes it just takes a little while. Obviously, the smaller the vessel, the tighter the bend, the longer it takes. And then you can just do a check angiogram. Again, it's check position, and if it is okay, you carry on, basically. Now, this is what I've done here is that we got down to the bottom of the thing, and we found that the microcatheter won't go past. So you could either treat it with a 1.0 blue, try to dilate it if the microcatheter doesn't go past, or you try another septal and just see whether you get another route to get to the location. So we went to a different route on this occasion, and you can see, again, checking and went down here last time. Now we're going to go around this way, and let's just see if that's going to work. Right. That's the thing, I've forgotten to say that. Using a microcatheter injection, always inject high up where the branch is bigger. Okay, you enter into the septal, then you do the injection there. Do not inject when your catheter is down, okay? Otherwise you will cause a hydraulic dissection and damage the collateral. So always inject at where the vessel is big. Now, if sometimes the wire is very small, and therefore, you may have to just serve with the wire without doing an injection. But those that are bigger, the septal larger in diameter, you can do an injection. Okay, so not for all cases. Let me just go back here. So what you do here, when you've got the microcatheter in place, sorry, I was talking. This has run on. So this is again a different route. You can see the wire is traveling through, and again it's just spinning the wire, letting it take its own course, and try not to push. And you can again do what we did before, to check the position, do an injection in the guide catheter to check the position. Once you've got your microcatheter in place, so you follow the wire with the microcatheter. You do not go ahead of the wire, okay? So always just slightly behind the wire, and then you withdraw the wire. You can either do an injection to check that you're in the right place, and or either through the catheter or through the microcatheter, okay? But you've got to be sure, otherwise you don't want to cause a dissection, otherwise that's the finish on that side of the septal wire, okay, the septal collateral. Then you follow with a stiff wire. Any idea, you can either use the stiff wire as a marker, so that you mark where you go, and then that allows you to go antegrade in order to reconnect. So this is just showing what you need to do to find a position to do the reverse cart. You need a dancing, kissing wire kind of thing. Okay, let me just show you there. Right, this is another case, just to show you out of the way. So this is a typical dual injection. You can see the occluded right coronary artery. You can see the distal vessel here. This is where the collateral, and this could be coming from either a antegrade on a branch from the right coronary artery, or it could also come from the septal. Okay. So the thing to do is take different position, different angles, usually a cranial view for a right coronary artery CTO, so you can see the septal. I'll just play that for you. And you can see there, you can see that septal coming down here. That's nice and clear, okay? And that's the target, and it seems to join down here, and it goes to the collateral down here. So that's the target you're going to look at. Apart from seeing that, you can look at the first septal, the second septal, the third, the fourth septal, and just look at each one in turn. You may have to freeze it and scroll it backwards and forward in order to get your eye into which of the branches you're going to select. And also, I think even the LAD down here, there's an epicardial collateral right at the tip that seems to join as well. But those are the ones that a last resort if you really need to do it. Okay, but otherwise, it's this general septal is the safest, just in case you perforate. It's not going to cause any harm. So this is just getting a wire down. There's another wire there just as like a buddy wire to allow the microcatheter to transverse through quite nicely. Again, you can just see the soft wire traveling through, and then it then allows you to do an injection to see where you are, and you can see there's a retrograde a microcatheter injection to allow you to visualize distally what's going on and where you're going to go for in order to link. Then you go for an antegrade and retrograde right wiring. Okay. So you can see that what I've done now, I made a knuckle, a microcatheter down the antegrade. I made a knuckle, and I'm knuckling towards the marker wire of the retrograde. Okay. And then you do what's called a reverse cart, and you just should freeze that for you. So you can see the double knuckle there. So that's the classical shape that you know you're feeling excited because everything is going perfectly well. You're going for the kissing knuckle, and you've got your guide extension all the way down. So you're going to, although the occlusion was up here, you've now brought the area of the occlusion down to right down to with the guide extension catheter to allow you to get into things. So these are the reverse cart, okay, controlled antegrade retrograde tracking, and this is a picture to show what we do. So basically, what you do, you got a retrograde wire coming down here. You've got the antegrade wire. You've ballooned this area. They're in separate, different channels or area. So what you need to do is to try and make one space. So balloon the space, trying to cause a fracture in the wall or the lining between the two spaces, and then you deflate the balloon and enter with the retrograde wire into the space, and then complete the procedure by externalization. Okay, so that's the whole purpose of what we're doing. And so here is what we've done. So I've got the guide extension catheter here. You can see the balloon I've inflated antegradally. I've got my retrograde wire knuckle here, and I'm just balloon it. And what you're trying to do is to create that space, the single space, so that both channel is linking. And then you try to enter into using a retrograde wire into the guide extension catheter. Now, sometimes you may find that this bit is the hardest of the lot, okay? You struggle and you struggle and you struggle. You've got all the things, you pat yourself on the back saying you've got to this point. All you've got to do is enter into this guide extension catheter. And that bit can take a long while. The reason is because the tissue plane between the subintimal tract and the real true lumen could be calcific, could be quite tough, and the way to do it, you've got to move it backwards and forward of where you're going to cross up and down this vessel. But the main thing is get a stiff wire, a retrograde stiff wire, and this is what I've done. And what I've done first is I use a bigger balloon. Okay, I use a bigger balloon in order to try and get into it. And what to do by inflating a bigger balloon, it allows me to make a bigger space, crack and split that tissue plane, and then the stiff wire to go through into the guide extension catheter.
So why the balloon is inflated, so you have to punch it?
No, no need to puncture the balloon, okay? Just make the space. I have it, so basically you inflate the balloon, and then you have a stiff wire ready, okay?
While the balloon
is up, when you come down with the balloon and you pull back the balloon, you can then go forward. You try to make it the same. It doesn't really matter that much, okay? Just inflate to break that tissue plane and use the stiff wire to get into the guide extension catheter. So this is what I did here. If you just watch that. So I've made the bigger balloon. There's the stiff wire. Then it goes into the guide extension catheter. Okay, you see that? So it goes into the guide extension catheter here. And the idea to get into the guide extension catheter is to bring the retrograde microcatheter into the guide extension catheter. Okay, the whole purpose is to get it so that it becomes one lumen, become a loop. And then you take your retrograde wire out, put an externalization wire, a long wire that comes all the way out, and then you're back to standard PCI. Okay, so that's the whole aim of the game in order to do that. So this is again, you see the wire traveling up the guide extension catheter. You're in the lumen. And generally, you're about a good 95% there. Okay, but there are a few things that you've got to be careful of. Of course, once you've externalized, you've got the big wire, the long wire that's going all the way out. You then got to pull back the microcatheter so that you're not blocking the way when you do your antegrade ballooning and stenting or whatever you want to do. And when you pull your microcatheter back, you've got to be sure that you disengage your retrograde guide catheter, okay? Disengage it, pull it out into the aorta, because it's on one long wire, it's not going to go anywhere, okay? Because you've got both ends. It's one wire. And so disengage it completely, bring the microcatheter back, because the microcatheter has struggled through tight septals to get down to where, when you put it back, it drags the main guide in. And that, unfortunately, have been many mistakes in people that cause a dissection in the left system, the donor artery, and cause more problems. So always make sure when you pull things back, it doesn't cause any dive in and dissect your donor vessel. Okay. So this is the final result. You can use IVES and all this. It's just standard PCI once you've got the externalized wire. Okay, and then the question is to take your retrograde kit out, which I'm sure the next speaker would mention about that. So in summary, for mastering retrograde septal techniques, you've got to examine the coronary angiogram for collateral filling in detail. Look for interventional collateral, with or without dual injections. Okay, choose the equipment you want to use to get the job done. So you've got to have all the wires and microcatheters and things that you're gonna need. There are no shortcuts. You've got to go through every step. Okay, any shortcuts tends to cause more problems. Just stick with the plan, then you're less likely to make a mistake. You've got to be patient, avoid aggressive wiring. That tends to be the reason why you cause all the complications, hematomas, dissection. Use a 90-degree bend, tip bend. I would suggest a 1 millimeter 90-degree tip bend. Have all the reverse cart skills. Have your kit, stiff wires, guide extension, bigger balloons, and IVES. And then sometimes you get your wire across, but you can't get your microcatheter across. And however you try, you can't get your microcatheter across. So my last tip is to do the tip-in way, where you get the retrograde wire up and you're trying to enter using the same wire into the microcatheter of the antegrade, okay? And that way in the guide extension. So you wire your antegrade microcatheter with the retrograde wire, and then you can follow it with the antegrade microcatheter, and then exchange out and become an antegrade system like you usually are used to. So that's sometimes when you get stuck, you've got everything across, but they've got the wire across, but the microcatheter just won't go across. Okay, so before you give up, that's the solution.